to that, we have a little bit of bittersweet news to share for those of you who did not see on Twitter. This is actually going to be the last week in what we're calling season 1 of the seminar. We just need a little bit of time to recharge and build a new content calendar up for what we want to be able to share with all of you, and like as we have for now. I think this is going to be the 18th consecutive week. So as this has gone on longer than we expected, it's going to take a little bit more planning to make sure that it can go on as well as we have. So thank you all for joining us. For those, I know many of you have joined us every week, so thank you for that. And for those who have come and gone, thank you for all your participation in the chat, viewing us, and all the support that you've given us throughout this period. It's been great for all of us to connect with each other during these very strange and odd and unique times. But with that in mind, we have another great seminar to share with you today. So to kick off the seminar, allow me to pass the conversation over to our always present and always able co-host, Sally Gainsbury. Sally, the floor is yours.
Thank you, Khalil, and thank you to everyone for tuning in again today. And do rest assured, we already have content lined up for season 2, and we will continue to build this. But very happy to focus on today's webinar and 2 fantastic early career researchers on the topic of how to digitize treatment and recovery. So today I will be introducing Dr. Dylan Pickering, who is a researcher at the Gambling Treatment and Research Clinic at the University of Sydney within the Brain and Mind Centre. Dylan has been with the Gambling Treatment and Research Clinic for several years, and he's recently completed his PhD. One of his roles is to evaluate the club's New South Wales digital multi-venue self-exclusion program for New South Wales gambling venues, and he's currently deploying with an Office of Responsible Gambling Research grant, a self-directed website to increase the accessibility and convenience of self-exclusion registration. His PhD focused on the conceptualization of recovery and how to measurement recovery of gambling disorder, and he's created a recovery index for gambling disorder. So Dylan is very well placed to bring together the theoretical understanding of gambling disorder and recovery and the application of technology for how to create aids for consumers and individuals to assist with their both seeking help and recovery and the maintenance of this. I'm also very pleased to have today Dr. Frank Iorfino, who's also within the Brain and Mind Centre at the University of Sydney. Frank's research focuses on understanding the emergence and course of mental health disorders and their impact particularly on young people, and looking at models to improve mental health care. His work looks at ongoing engagement with health services to maximise the translational impact of research and the development of new technologies which aim to enhance the way service delivery of mental health is delivered. So with that tripping over my tongue, I will definitely start by handing over to these 2 fantastic early career researchers who are going to briefly share a few slides before we get into a conversation on this topic of how to digitize treatment and recovery. Over to you first, Dylan.
Thank you so much for that lovely introduction, Sally. So is that slide up now? Excellent. Okay, so I just firstly wanted to start with a question of why do we need to digitize treatment and recovery in the first instance? So the starting point for that is that research suggests that less than 10% of individuals with a gambling disorder will actually seek formal help. So that leaves 90% that aren't necessarily getting the help that they need. So researchers looked into some of the key help-seeking barriers. And among those, one is social disadvantage. So just for example, a person living in a remote or regional area and not able to physically access treatment services, or simply they can't afford to seek effective treatment as well. Another common reason is that individuals, they're either too embarrassed or ashamed to get treatment face-to-face due to perceived social stigma that surrounds addictions, or just maybe initially they want to try to cope with the problem on their own first. So although right now I'm speaking about gambling disorder, you may notice that many of these points also hold true for other addictions and mental health disorders as well. So digital and internet-based interventions can potentially provide a viable treatment option for those that are either reluctant or they're unable to access traditional face-to-face help services. Purely from an economic perspective, these treatments have demonstrated ability to produce positive outcomes in a larger number of people and at a reduced cost compared to face-to-face treatment. Can we just go to the next slide now? Okay, so I drew this 4-quadrant graph to roughly show where some of the more common online interventions sit on a spectrum of the individual's recovery stage to the level of their autonomy within the intervention itself. So on the horizontal x-axis on the left-hand side, I've written in interventions that are more appropriate for people at the initial onset of a gambling problem, and all the way to the right, interventions that are relevant for people that need continued care and maintenance after they may have received a treatment. On the vertical y-axis, with online interventions in psychology, they're often referred to as a low or high intensity. So the main defining feature of this, it refers to the level of contact that the person actually has with a qualified health professional. So obviously on the low end, no to very low contact, on the high end, higher contact. So if we were to look at this graph from a stepped care model perspective, we might generally expect to see treatments for lower severity problems in the bottom left quadrant, and more severe gambling disorders in the top right quadrant. So moving from left to right in terms of the data points, at least in the gambling literature, brief self-directed and self-directed with clinician support interventions have received the most research attention. That's why I've put them there with larger dot points. And the research has generally shown positive treatment outcomes. However, unlike other disorders, it's currently unclear if the effects are equivalent to face-to-face therapies. This is something that we're working on at the GTRC at the moment with a randomized controlled trial. And by comparison, looking at the data points on the right-hand side, the evidence in the gambling field is lacking with respect to high intensity video conferencing therapies that are delivered through like Zoom or Skype, as well as lower intensity relapse prevention and recovery support tools, which are offered to patients generally after they've received the higher intensity therapy. Can we just go on to the next slide now? Great. So in addition to delivery of services, digital technologies can also be used to enhance the assessment and monitoring of treatment and recovery outcomes. So first, I'd just like to focus on a technique called ecological momentary assessment, or EMA. So this uses mobile technology to assess people's current thoughts, their behaviors and moods as these occur in real time and in the person's real world context or settings. One of the benefits of EMA to gambling research is that it can be used to attain a more accurate measurement of self-reported gambling behaviour, which, as we know from the literature, suffers quite poorly from bad memory recall biases in the more traditional retrospective surveys, where they might ask someone to report their level of expenditure over the past month or something. In addition to this, EMA can also be coupled with ecological momentary interventions, also known as just-in-time interventions. And these prompt individuals to perform self-help exercises at the time that an urge arises, as measured by the EMA technique. One example of this is the Curb Your Urge app, which is currently being tested at Deakin University in Victoria, Australia. And so just staying on the mobile app theme, another potential use, one which I'm particularly interested in, is to self-monitor gambling treatment and recovery outcomes over time, particularly after treatment's been received, and as a way to provide an ongoing maintenance and support through feedback and tailored support. So this is quite similar to the personal tracking functions that are found in health apps for physical activity, sleep, diet, drinking, and smoking. Where research has shown that the monitoring process just by itself has been shown to sustain healthier behaviours and potentially prevent relapse of more problematic behaviours. So I think I'll throw it over to you now, Frankie.
Thanks, Dylan. Great talk. I mean, there's a lot of overlap between our two areas, which is really great. So as Sally mentioned, I'm from the sort of youth mental health field, and specifically we've done a lot of work with health services. And so, through this, we've engaged with communities. And, when we do that work, we hear the same things often about the health system a lot of the time. It's too complicated. People often have to repeat their story or their situation many times, difficult understanding what the different treatment options are. And, there's often navigating between different providers to get what people need is often challenging. And so when people have these problems are particularly problematic for people with more complex needs who present with higher rates of, say, suicidality or comorbidity. And so we've spent a lot of time figuring out how to effectively integrate digital technologies with service pathways to really improve the way mental health care is delivered and coordinated. And so figure 1 here shows what a redesigned technology-enabled service pathway or service model might look like. And so while coordinated care approaches are not exclusively carried out by digital technologies, their accessibility, their scalability, the standardization of them means that they are well placed to facilitate many of these care coordination processes. So things like facilitating faster communication and case planning between different providers, or more systematic and standardized assessment at entry into services. And so this is important for people with more complex needs when you have to coordinate housing support or employment support, whereby mental health treatment may be an additional burden of time and effort and finance for people. So technology offers an opportunity to alleviate some of the time burden, some of these burdens through greater flexibility for accessing treatments and greater efficiencies through the sharing of information between providers. So here, you can see on the left side, with the low intensity interventions can be delivered online, clinician assisted, and you have video visit sort of functionalities as well available for treatment. Next slide, please. Now, if we focus on a person's individual pathways, in mental health, youth mental health, there's major heterogeneity in a person's illness. And so predicting outcomes or trajectories of illness is very difficult. So in practice, determining when to adopt specific intervention strategies and for whom is very challenging. And so as you can imagine, this is even more challenging when someone first presents for care, where you only have a single point estimate to go off, or one assessment point, and very little information about which direction that they may be trending in. So only with more rich and continuous measurement-based care can you start to build a clearer picture about someone's trajectory, and then hopefully gain some insights into what works and doesn't work for them. And so this sort of systematic and continued assessment to make decisions is what we call measurement-based care. And EMA, as Dylan mentioned, is one of those sort of approaches you could use for it. And this is a really core component of most chronic care models, where you have people oscillating between health and illness over time, over long periods of time. But in mental health, these sort of, we've been limited, and these approaches aren't used systematically and mostly because, there's often a reliance on traditional face-to-face assessments and monitoring. Yet this is obviously where new technologies can rapidly transform this space. And so in this paper here, we presented the concept for a digital platform which aims to facilitate these processes within a mental health service. So it helps with assessment at entry and over time, provides feedback so that, we can manage and monitor someone's mental health by collecting information from various sources. And so prototypic work on this platform has shown that it can facilitate more broad assessment of the totality of someone's needs at entry into care, and it can help a more appropriate and timely response to people entering care with highest levels of suicidality. And so if you see along that line there, you can see that, at different points along the care pathway, a person's outcomes are being monitored and tracked, and, interventions can be changed accordingly. And so this is where, you can connect with other technologies such as mood trackers or sleep trackers, so that you can monitor someone's progress over time. So services can increase or decrease more efficiently to match the type of care that someone requires at any given point in time. And just on the final slide now, I just wanted to speak a little bit about measurement-based care and technology in the context of helping us deal with the complexities of mental health and enhancing clinical decision making. So, mental health often arises from the complex dynamics between many social, psychological, and biological factors. Yet we often still rely on mental models of these complex dynamics when we make decisions about treatments. And so with the better use of technology infrastructures, we can provide richer inputs for measurement-based care. And so through the use of EMA, but also other further assessments such as cognition, assessments about cognition and behavior that can also be delivered through online tools. And this is what makes measurement-based care more than just sort of outcome monitoring, because rather it's about collecting relevant information to make more informed decisions from various sources. And so if we can start to integrate this information with AI approaches, then we may be able to uncover unique patterns in a person's mood and behavior over time, which could be used to inform more targeted treatments for a given individual. And such tools can help us identify what piece of information do we need next to reduce our uncertainty about what is going on for someone, or increase our confidence in what might work for them. And this will help us move away from those sort of mental models to more informed data-driven models of mental health care. And really this allows us to create a system whereby we are being guided by best available knowledge about a person, and then constantly learning so that we can provide more targeted mental health care to improve a person's outcomes. And I really like this sort of figure from the World Economic Forum report on mental health care and technology, because it really gives you a really good overview of the sort of breadth of things available in the technology ecosystem in mental health care at the moment, which ranges from the EMA's type of stuff with a focus on monitoring to, other biometric tools, to AI sort of models. And so, the sort of opportunities are endless in this area, I think. And I think that's where I'm going to leave it before we go on to a more broader discussion.
Thank you both, Dylan and Frank, for those really interesting presentations. And I think there's so many questions and different areas we could go into. I suppose there's two different aspects in my mind. Maybe we can talk about one at a time. One is obviously, what are the tools? What are the most effective ways of providing this? But also then thinking about the people, who's going to use this? Obviously, when you have face-to-face therapy, you customize what you're providing to the individual, at least to some extent. But when you're creating something online, particularly when it's relatively self-directed, there is that lack of ability. So maybe I'll start with you, Dylan, and then go to Frank. Because of Frank, you've obviously focused on young people. But Dylan, maybe to start with, what have you learned from your research to date about consumer preferences for accessing interventions and recovery online? And how can we develop interventions and tools that are digital and autonomized, but also catering to the preferences of individual people?
Thanks, Ali. Yeah, it's an excellent question. So, as you mentioned in my introduction, a lot of my research to date has focused primarily on self-exclusion programs for gambling. Though these findings, I believe, are also relevant to other online interventions and recovery supports as well. So at the moment, I'm working on a project to develop and pilot test a self-directed website for self-exclusion registrations. That the person does not need to have the assistance of a venue staff member or counsellor to actually sign themselves up for self-exclusion. So the impetus for this work were a series of mixed method studies of individuals involved in an existing self-exclusion program, which is the multi-venue program offered by Clubs New South Wales, where self-exclusions must go through a counsellor or venue staff. In our research, we found, as a rough estimate, about 3 out of 5 people indicated that they would have preferred an online self-exclusion option. So this is the majority, but it's also, I think, important to point out here that there is still a considerable portion of people that still prefer the traditional pathways into this service as well. So more recently, we conducted a qualitative requirements analysis with focus groups with consumers, as well as other stakeholders like counsellors, venue staff, and relevant policymakers, to find out what their preferences were in terms of the key features and functioning of an ideal self-exclusion website for gambling. Surprising to us was that the responses between these groups were actually quite similar. We expected the consumer preferences to differ quite a bit, say from counsellors or clinicians, but they were consistent a lot of the time. So if I were to set aside some of the specific self-exclusion type requirements, the general attributes of the technology that were highlighted by our participants are relevant to all online interventions, I believe. So one of those was user friendliness. Obviously, if they're doing these things on their own, it must be really easy and simple for the end user to navigate and use the functions of the intervention. And it also must be flexible, in that the service needs to accommodate the individual needs and expectations of each person that will be using this service, which are often quite diverse. So just as an example, these type of services would need to be provided on smartphones, tablets, and desktops, depending on what the person uses to access the internet. Another key feature was that they need to be credible and trustworthy. So the person needs to be reassured that the service it's legitimate, it's safe to use, it's secure in terms of their privacy and anonymity, which is very important for particularly for patients seeking help for addictions and gambling disorder. And finally, the digital interventions, they need to be encouraging and motivating for the person. So often, for instance, with a self-exclusion program, the individuals trying to access it are quite ambivalent about their decision to make this change. They still, on the level, do want to continue gambling, but they also realise that the costs at that moment are outweighing the benefits. So it's important that they, that in the design, in the content and the aesthetics of the online service, that there's always an effort to positively reinforce the help-seeking behaviours.
And Frank, what's your experience then with younger populations?
Yeah, so similarly, when we've been developing these technologies in the context of young people and health services, engaging the groups that the technology is being developed for is really important. Otherwise, there's often no sort of, otherwise you end up with something that isn't really being used, or is not going to address the sort of needs that group is requiring. And so, we've done a lot of participatory design workshops with communities and groups to try and figure out what are their preferences in terms of using technologies. And with the thing is that there's huge variability in what people want, and often young people have such diverse needs in terms of their mental health. And so really we've focused on trying to develop sometimes there's a need to develop a range of tools, but then bringing it together within the context of a health service. And so having access to the different types of tools someone might require, but then bringing it together in the context of their health care is really important. Being able to access that through a platform, but then also integrate the various things that someone might be using, so that you can start to track their outcomes in more effectively, and rather than sort of having to go to different sources to get that information.
I think that's a really good point, that ability to get more data and track outcomes. Maybe you could explore a little bit more about that. And you've mentioned previously AI and some of the new innovations and ways that this technology can be used to enhance treatment delivery.
Yeah, so I would say that monitoring outcomes is crucial to being able to determine if an intervention is successful or not. And again, monitoring the right set of outcomes is important here, because recovery and interventions and an intervention success shouldn't be one-dimensional. So it isn't about just symptom reduction, but about addressing a range of needs that a person might have. So, are they using drug and alcohol, or are they smoking? What is their physical activity like? All these things are really important for a person's mental health. And time is another key factor when trying to evaluate the success of an intervention and recovery. So have the improved outcomes been sustained for a significant period of time? And this, again, is where technology offers really great benefits. I think even once the intervention has stopped, being able to monitor those sustained improvements is important, so that if deterioration along some dimension starts to occur, then the right and timely response can be enacted to get someone back into treatment before things deteriorate further. And so as you mentioned, you know, AI is a sort of emerging area in this field, and I think it's inevitable, given that, you know, using new technologies comes with, you know, access to new data and lots of data. But it's important that we start using that data in sort of in a way that not only it enhances care and helps us learn about what works and doesn't work. And you know, we know that prediction is an essential part of healthcare decision making. Yet really its clinical utility depends on understanding causation and to start building theory about what might be driving specific outcomes so that we can understand how to intervene effectively. And so, you know, traditional sort of machine learning approaches might not be the most useful for this, because they can be misleading, because they may give you, if it's just focused on predictive performance, then these tools could just sort of really expose correlations without really, which could improve prediction, but really might not give you what you need in terms of understanding what is driving a particular outcome, which is what you need to know to intervene effectively. And so trying to use smarter approaches that can help you understand these causal relationships and improve, integrate information from data, but also information from scientific theory and clinical knowledge to help understand causal patterns in sort of these models is going to be really important. So it's sort of the interface of clinical expertise and data to try and improve decision-making in some sort of meaningful way for clinicians and services.
Frank, I just had a follow-up question on that, if that's okay, if I ask it now. So one of the struggles that I've had in terms of developing like this online self-exclusion intervention is if I try to cater for too many people, I might be losing the specificity of the target population of who I'm trying to reach with this online technology. So while flexibility is important and meeting individual needs is an important thing to do, firstly, the question is there a case where we can spread too thin in a sense? And as a follow-up, like some of the systems that you're speaking of deals with youth mental health and decision-making around clinical decisions. How does, like the Diagnostic and Statistics Manual, it's full of different mental health disorders. Is it effective in discerning between those different disorders and the unique features of each disorder and coming up with appropriate plans to treat each of those?
Yeah, so I think your point about flexibility and, you know, the challenge of you know, different types of illnesses and is a really good one, because, yeah, I mean, and it also speaks to why monitoring is really important. I mean, monitoring, that is really like an N=1 experiment, right? Like, you know, you start to understand someone's trajectory, and then you can hopefully start to build an understanding of what works for them specifically. And so in that context, I think, you know, AI can start to help with that N=1 experiment and trying to plot someone's trajectory over time, so that then you don't have to you know, focus in on any one particular group, and that you can just focus on that individual and personalizing treatment for them. But also, I mean, trying to deal with the heterogeneity of disorders is partly why, you know, these approaches could be really useful, because, you know, in terms of trying to cluster groups in terms of who might be on a trajectory like the one I've seen before, is sort of a question that we can start to ask of these types of tools that we might be using in services or for treatment. And so I think it depends on, it is important to get the questions really sort of specific. So, you know, what is the outcome or that you're trying to predict or optimize for, and making sure you know that that's the parameters or that's the scope for that sort of tool, and that, you know, you need to look to other tools if you want to try and improve other outcomes as well. So it's not going to be like a sort of silver bullet for everything that's going on for a person. I don't think, you know, we have tools that can help with risk detection, or tools that can help with optimizing someone's functional recovery, and so on. So I think I think that's probably the way we need to go about it. Does that sort of answer your question?
Perfectly, yeah.
I guess, Dylan, that's one of the questions. Obviously, you're so familiar with this literature and area of whether there's anything specific about the gambling field that does require any differences or catering, or whether the gambling field can start extrapolating some of the apps and technology directly from the broader mental health field.
Yeah, that's an excellent question, Sally. So in my like, this is my own perspective of the literature, but it reminds me of something that was written by Professor Jim Orford, who's a professor in the UK for problem gambling treatment, and he mentioned that problem gambling treatment it's lagging behind other areas, particularly substance misuse, by about 20 to 30 years in terms of the treatment effectiveness. Look, perhaps that's a bit exaggerated, but there is some truth to this statement, because although that cognitive behavior therapy does have the largest evidence base with gambling disorders, there's still no clear gold standard treatment approach for it. So what Frankie was speaking about is the ability for services to link up, I think, which is something that's really important, that needs to be done more in the gambling area. So my PhD was looking at how to conceptualize and measure gambling disorder. And what I found, one of the key findings of that is that recovery is a multi-dimensional construct. So it is made up of gambling specific domains, of course, so gambling symptoms and behaviors, things like urges, but it's also made up of non-gambling specific domains as well that are affected by the person's gambling behavior. So for instance, their financial well-being, their interpersonal relationships, their mental health and occupational functioning. And these are all things that should be dealt with or addressed in the treatment process. So if there is a lesson that can be learnt from the work that's being done in the broader mental health field, I think definitely is the more integration of services for gambling help, and using digital technologies to facilitate the communication between these services, and the ability to monitor individual patient outcomes, and for the different services to be able to access these and to track patients that are being, I suppose, monitored by different providers. Hopefully that answers that question.
I think you've picked up exactly the point. I think the gambling field sort of could learn from the other area, or the broader mental health field, because that is one of the things one of the major challenges in this area, is trying to integrate all the different types of tools that are being used in sort of some meaningful way for a person. I mean, a person shouldn't have to have sort of, 10 different apps that they're using on their phone. I mean, so it might be useful for some people, but I think being able to integrate these things in a meaningful way is really important. But then also between providers, that's where people can often fall through the cracks, trying to be, when they're being referred to another service, or, it could either mean they have to repeat everything again, so repeat all the assessments they've already done, or they don't make it over there because something, just transferring from to a different service can be challenging. And so technology can really try and help us make this transition more seamless, really, and making sure that people are having their needs across these different dimensions addressed more effectively, and they're not having to repeat their story a million times to different clinicians. They can just have it assessed once and ongoingly, with making and then giving access to the people that need access to those assessments over time. So yeah, I think you really picked up the main point, I think.
One potential challenge that just came to me now, maybe you could speak to this, Frankie, with your experience, but with the integration of these different services, I can just imagine that a professional in one area, say psychology, and if someone's seeing also a financial counsellor and a general practitioner, everyone in these areas comes from different disciplines, and they may believe that their way is the right way to treat this particular person. How could we potentially deal with those differences of perspective on how to best treat that particular patient, and to make sure that that person is getting consistent and a cohesive treatment, and not getting contradictory advice, I suppose, from different mental health professionals and health professionals?
Yeah, I like this question because I think it really comes down to the person, right? This is what technology can really change and shift in sort of healthcare, I think generally, not just in these fields, but, people traditionally haven't really had access to the notes about them, or what is being collected about them. And there's that relationship where they're receiving the care rather than being an active sort of participant in those decisions and the decisions made about them. And so I think what technology can do is really, it's sort of like a slogan, but it really does put the person at the sort of center of their care. And so, the different clinicians that might be involved, if there are sort of discrepancies in terms of what they think should be done, I think it ultimately should just come down to the person. There are some circumstances where, you can't often do that, but most circumstances should be, the person should be an active participant in the decisions made, and it should be more of a conversation about what should be done. And so hopefully technology can be that conduit between the different providers and the person, so that everyone is on the same page, and then they can move forward knowing that, this is your role, this is my role, and this is the person's role in their own care.
I think that's a really important point, because obviously some of the people watching this webinar or listening on the podcast may not have access to be able to build their own technology product and interface. And I think one of the aims of this is that everyone doesn't have to, that there should be scalable apps and models out there that can be shared between clinicians. So maybe Dylan, you could describe how you think clinicians could engage with the available technology that's currently there or that might be developed in the future, how that can be integrated into either, whether it's while you're on the waiting list or people who are not ready for treatment, whether it's something that can be aftercare. How can people who are currently working in the gambling field and interested in supporting individuals at various levels of problems, how can people start to encourage people to uptake and integrate these sorts of apps into their work today?
It's an excellent question, and I think it speaks to a blended mode of the use of face-to-face therapy and technology as well. So an immediate use of, say, mobile app technology that comes to my mind is the ability for a clinician to monitor a patient's outcomes and progress as they go through the treatment process. For instance, if they were to, I'm not giving this a plug, but if they were to use a recovery index, which I developed for my PhD, they could potentially be monitoring the person's progress on different dimensions, and hopefully that will be put onto some type of mobile app platform. And we could use things like ecological momentary assessment, where the assessments aren't necessarily done once a week or once every 2 weeks when the clinician sees the patient, but they can be done on a more regular basis, and that clinician can be keeping up to date with how their patient is going, which would allow them to prepare for sessions and to organise what type of therapy that they're going to deliver on a week-to-week type of basis. Similar to that, once the person has gone through a more intensive therapeutic process, the clinician can then potentially use something like a relapse tool or recommend that type of technology to for the individual to be able to maintain the positive outcomes that they have got from that treatment and not experience relapse, which we certainly know is there's quite a high risk of with behavioural addictions.
And Frank, obviously the youth mental health has really embraced technology, I think probably being at the forefront, given that young people are so much more comfortable online and potentially even prefer to seek help online. How have you seen technology embraced in the treatment and intervention field in the youth space? And is there anything that you think that other addictive fields can learn from that?
Yeah, I think it's true that, you know, there is definitely a movement, and there is good uptake in the field. I think there's still so many challenges with it though. I mean, we see most apps and e-tools used in this area, you know, they follow a similar curve where they sort of start out with high use and then there's a huge drop off after, I don't know, a few months or something. And I think that's okay though. I think it's part of it should be accepting that there might be high drop off, and that maybe the tools need to be dynamic in a way that, you know, there might be periods of high use, but then periods of low use. And then it's about how do you get people back into those tools when they need them. You know, as I sort of mentioned, you know, people oscillate between health and wellness and ill health. And so, you know, accepting that some tool might drop out, but then trying to figure out how to make sure that you're checking in often enough to then bring them back when they aren't going so well. So I think that's really key in the design of the technologies. But also just from the other side, in terms of the youth field, yeah, there are challenges with, you know, its uptake across the field in terms of different clinicians and services. So there's great variability. You know, some clinicians are really forward thinking and really and like the use of these sort of new tools, whereas others aren't so familiar with it and maybe not haven't been exposed to it. And so that difference in uptake across the sort of from the clinical side of things, I think, is a barrier, because, you know, sometimes, because then if you see one clinician, they're using it, and you see another and they're not using it, that can be real, I think, really off-putting for young people, and then that's where sort of the use could sort of drop. And so I think education and training about the utility of these different tools and how to use them, and trying to encourage the more systematic use of these tools in these environments is really important. Otherwise, if you just have a few actors using them here and there, then I don't think the adoption is going to be so great. And that's been a real challenge.
Noticed a really interesting question from Julie Hines in the message board, and it was speaking about the effectiveness, in terms of re-engagement and retention of clients. And I definitely, when we are speaking about technology today, but I definitely don't want to put across the perspective that it is the solution to all the problems in the clinical world, whether it comes to gambling or other mental health disorders. And one of the things that we do know about online interventions is one of the key limitations is dropout, as compared to face-to-face interventions, because they're not getting that regular routine contact with a therapist. But in saying that, there are also some ways that technology can be used to increase, say, re-engagement with a patient that a clinician has seen for a period of time. And if they were to suggest some type of relapse or recovery tool, if the clinician, and this is hypothetically speaking, did have access to the data that was coming from their ex-patient or something like that, they could actually monitor if this person was experiencing some type of deterioration, and perhaps get into contact with that person and see if they need to re-engage with a more intensive treatment approach.
Yeah, I like your point, Dylan, about you know, face-to-face being really effective at engaging people, but then you know, technologies, I think, can extend the face-to-face. And I think in terms of addressing uptake and getting people on board, you know, that clinical time, that face-to-face time is so valuable, yet it can be often quite sort of spread out, I suppose. And so, you know, thinking about how to maximize the face-to-face time for what really needs to be done face-to-face versus what can be done using technology. So, you know, those assessments, you know, unfortunately, I think, you know, we're starting to see that assessments can be more effectively done by technologies. You know, they're standardized, they're more systematic. And so, you know, trying to do everything in a face-to-face session can be challenging, I imagine. So, you know, trying to offload as much to the technologies as you can really helps enhance the face-to-face time that you do get with clinicians. So, and trying to find that balance is really important.
And we're coming up towards the end of the webinar. Time always flies, and I still have a million questions for you both. So maybe just to finish, or as we're getting towards the end, what I'm interested in is to hear, maybe starting with you, Dylan, of what you would encourage people working in this field right now to start doing, whether they're clinicians, whether they're, community support workers, whether they're researchers. What are your kind of top takeaways for how you would like the field to progress or advance, and what people can do right now?
Right now, I think the best strategy is to perhaps for people in this field to keep an ear to the ground and keep an open mind about technologies that do arise that could potentially help them within their day-to-day job. And I think Frankie made a great point, is that technology can potentially actually enhance the face-to-face time that people have with their clients by taking away some of the tasks that were traditionally done face-to-face that are more efficient to do via technology, like things like assessments and that. So I'd recommend just keeping on top of the literature as much as possible in terms of what new interventions, what new tools are coming out, and how they could potentially be integrated with day-to-day practice, I think.
And Frank, coming from outside of the gambling field, one of my questions is, obviously for us as gambling researchers, we see a lot of issues with young people. However, there's a huge number of people working in the youth field that aren't really aware of gambling problems or focusing on them. I was wondering if you could reflect on your experience of whether gambling does come up at all outside of if you're specifically working in that field in the youth mental health, and if not, why not? And maybe what can we do as working in the gambling field to increase the priority of people working with young people to focus on that as an issue?
Yeah, when you invited me to speak here, I was reflecting on that very point about how I haven't really, it doesn't really get talked about so much in the youth field, youth mental health, field about gambling specifically, which is a shame too, because I think I don't know much about the gambling field myself, unfortunately, but I would think that often the gambling addiction and addiction in general obviously is associated with youth mental health, and so the way it manifests through gambling might be a thing that happens later in life. But addressing those underlying sort of problems in youth and adolescence could be effective at preventing those behaviors such as gambling in adulthood. So I think that should be much more at the forefront of youth mental health treatment, about at least the underlying factors that are associated with gambling, and that tends to lead to those types of behaviors, because maybe they could be effectively addressed in youth to prevent those things happening later on. But then also, I'm sure that it would have other impacts in terms of drug and alcohol use and other things. But in terms of why it doesn't get spoken about, I imagine it has to do with prevalence and also just in terms of the other things going on for young people at that period of time. So I think that is an interesting area, and in terms of additional research, perhaps something that people should try and look at in terms of how to increase the focus on at least this sort of the behaviors associated with gambling in young people that might put them at risk in the future.
I appreciate that insight, and I think that's good lessons for us. We are aware that the gambling isn't always on everyone's radar screen, and I think it's important for everyone to continue to have those conversations. And certainly I know that in New South Wales, the Office of Responsible Gambling is making an effort to involve youth practitioners in understanding gambling. And I think for us at the Gambling Treatment and Research Clinic, we're trying to work with a range of stakeholders to increase the awareness of gambling. So I think it's an important reminder for us to continue to push the importance of, as you say, the prevention of gambling and engagement in gambling problems not only can prevent the immediate gambling harms, but also a proliferated effect of much broader harms related to all the comorbidities and issues that go along with that. And so efforts to prevent gambling harms are likely to be preventative for other aspects as well. So that maybe that dialogue and using that engagement technique is really useful for us. So thank you for sharing that. As we come to the end, what I'm going to do is ask each of you to just briefly summarize any final thoughts you have, whether it's a wish list of what you would like to do in your research going forward, or any kind of final comments.
I suppose I'll start off. I think I just wanted to speak to where I believe that are the most important areas for future research in gambling in this area to proceed to. So what I would like to see with online interventions is more robust evaluations of internet-based treatments for gambling disorders, and not only looking at whether these treatments are effective overall, but actually investigating how individual treatment components translate into the online delivery mode, whether they do or don't. And also, what are some of the limitations of internet-based treatments? As I mentioned before, the high rates of dropout. Can this potentially be reversed in some way? In the tech world, there's a lot of talk about things like stickiness with apps. Is this a concept that we can potentially try and bring in to increase and enhance engagement and uptake of digital interventions? The other thing I'd probably want to see more of in the gambling research field is to explore potential applications of new and emerging technologies to solve some of the existing problems that we have in the gambling research field. So the ecological momentary assessment's a good example of one way that researchers have tried to address some of the issues of self-reported gambling expenditure through the retrospective type survey design. So more innovative and novel ways to use digital technology to enhance the gambling research field as a whole.
Yeah, so for me, so I'm very interested in translational research and clinical decision making. And so, clinicians are asked to make decisions every day about who requires further assessment, what types of treatments is most likely to be appropriate and effective for a person. Yet, in mental health, we often lack useful markers, which means that these decisions are generally based on broad clinical guidelines or risk assessment tools or clinical intuition, each of which have their own limitations. So, I think this reiterates the challenges that health services and clinicians face when trying to deliver treatments that are effective. But this is where there is a need for innovation and innovative solutions that can improve the consistency and the effectiveness and the safety of clinical decision making. So I think that the focus on clinical utility will be helpful for the effective translation of these new innovations and technologies into everyday practice. Otherwise, we risk developing technologies or solutions that nobody really wants or needs or finds useful. So I think that's where my focus is and where I'm really excited about where things are going in this area.
Well, I want to really thank both of you, Frank and Dylan, for such an engaging conversation. And it's a really important area, and it's great to see how much both of you have already achieved in this area, and no doubt will be leading the field in both of your respective areas to come. And it's also a great way to finish our first season by featuring two early career researchers from the Brain and Mind Centre, which has provided support for this webinar series from the beginning. We don't have any financial support, but we have had fantastic support from the Brain and Mind Centre, and particularly from Harrison Stein, who has tirelessly worked in the background with Khalil and I. So a huge thank you to both you, Dylan and Frank. A huge thank you to the Brain and Mind Centre and Harrison in particular, and a thank you to all of the guests who have featured on this program, to Khalil, to all of the people who've watched and tuned in and sent us comments. The audience has been so engaged. It's been such a pleasure to host this. What probably I think we would have thought, if you'd asked us at the beginning, we would have strung together maybe 4 or 5 webinars, and this is now our 18th in a row. So it's been such a pleasure, and really this has filled a gap in the conferences. Maybe this time Next year we'll all be at conferences again. I'm not sure, I can't speak to that, but we do intend to revisit this and bring back the technology risk and gambling webinar series. So if you have any suggestions for speakers and topics, please do keep emailing Khalil and I to let us know. We'll bring back an excellent lineup for when everyone's ready to have an hour back in your schedule, and when you're ready to recommit to some future watching. We're going to keep posting all of the content online that's been created so far. So if you've missed any episodes, please go back and have a look at those. Please share them with your colleagues. I know some people didn't find out about this webinar series until relatively recently. So please do feel free to share that content, because that's a really great way of achieving our aim, which is to promote the early career researchers and the fantastic work they're doing in the absence of the conferences that are happening around the world. So, well, my last thing to do is to have a huge thank you to my co-host, Khalil Philander, who is as harebrained as I am to commit to this and agree to this ongoing webinar series. And it's been such a pleasure to work with. So huge thank you, and hand over to you, Khalil.
Well, thank you very much, Sally. And again, thank you, Dylan, and thank you, Frank, for your great presentation today. Yeah, allow me to reiterate everything that Sally said. It's been wonderful to work with you, Sally, as well as all the talented speakers, both early career and not so early career, that have appeared on this program, as well as everybody that's shown up in the chat room and has sent us emails and support along the way. If you are interested in hearing about future sessions, if you've already registered for one or more of these sessions, you should be on our mailing list. And so you'll hear about any future announcements for upcoming presentations. But you can always follow either Sally or myself on Twitter, or you can subscribe on the YouTube channel as well. And you'll get pinged a million different ways about how you can hear about the next session. But for that, thank you all very much for listening again this week, and we will see you